Okay, first of all, thank you to invite me to do this talk. For me, it's a pleasure to be here, sharing the knowledge. And I will talk about the differential diagnosis in long COVID based in a clinical real case. I have nothing to disclose. So starting with post-acute sequelae of SARS-CoV-2, as Peluso published, it is an umbrella of post-hospitalization syndrome, a new or worsened conditions, and reserving long COVID is for unexplained medical condition. As you know, long COVID is a multi-system disease. There are described more than 200 symptoms in this patient. And in the clinical practice, you know, the patients maybe seems that are distributed later in clusters. But the important thing or the message that I want to give to you is that it's our responsibility to make an accurate differential diagnosis in this population and not assume that everything is due to long COVID without a proper investigation. So I present you a real clinical case. It's a woman, 51-year-old, that she has allergy to metamizole. And about the medical history, she has multinodular goiter that now is stable with an euthyroid Hashimoto thyroiditis and an iron deficiency anemia with a colonoscopy with 2 polyps. She experienced an acute infection of SARS-CoV-2 in March 2020. No microbiological documented tests are done, and the patient didn't require any hospitalization, and the main symptoms were fever, dyspnea, tachycardia, headache, and anosmia. The symptoms persist after 3 years, so we visit in our long COVID unit. The first visit was in March 2023, and we pass to the patient a symptom questionnaire, as Lourdes Mateu showed you yesterday, with the following symptoms: low-grade fever, severe fatigue, dyspnea, chest pain, tachycardia, arthralgia, myalgia, headache, neurocognitive complaints, gastrointestinal disturbance, and visual alterations. The patient complete different assessment scales and with a score of 2 in the post-COVID functional scale. She has a score of 63 in the fatigue severity scale. She took at 18 seconds to do the 5-time sit-to-stand test. And finally, she scored a 9 in the Huda state of neurocognitive conditions. In relation of the laboratory test, she presents a normal hemoglobin according to the anemia. She persists with a D-dimer that was elevated, more than 1,000. The acute reactants were normal. The autoimmunity profile were negative, instead a slightly elevation of factor rheumatoid. The thyroid analytics were normal too, and she present a mild descent in CD4 and CD8. The evolution of the complementary test show us an anemia of hemoglobin of 8, so we rule out gastroscopy because the patient explains melena, and it was normal. Because of the elevation of the dimer, the dyspnea and tachycardia, we rule out a pulmonary embolism. And because of the persistent low-grade fever, we rule out 2 different serologies. We add the beta-2 microglobulin. The blood cultures were negative, and we asked too for an interferon gamma that was negative too. In relation to the gastrointestinal disturbance, no occult blood was in the stool, and the study of pylori, antitransglutaminase, and calprotectin were negative too. Finally, we performed an echocardiogram and a Holter 24 hours that both of them were normal. 1 year later, in March 2024, the patient persists with the same symptomatology, some of them with a worsening of the symptoms because of the impossibility to take anti-inflammatory because of the melena, so the arthralgia and myalgia worsening. But the patient present 10 kilos weight loss in 2 months and a profuse sweating. So maybe this is obvious that it's a red flag, but we are visiting every day a lot of patients during years. So we are internists or primary care, so we have to have these signs like red flags. What happened? So in the physical examination, it was obvious that the patient showed us a supraclavicular lymphadenopathy. So we request for a PET scan that show us a supra and infradiaphragmatic and splenic lymphoproliferative involvement. And finally, we decide to do a biopsy of this lymphadenopathy that confirms the diagnosis of follicular lymphoma. The patient has long COVID too, but she has now a lymphoma. So based on the different symptoms that we have in our patients, we have to do a differential diagnosis and think about the screening test or the test that we should do. In relation of fever or low-grade fever, like an infectious disease specialized, we should think about bacterials, virus, tuberculosis, but as well about the tumor origin. So it's important to do, of course, blood tests, but add in our analytics serologies, interferon gamma, beta-2 microglobulin, and PET scan, for sure. If the patient explains fatigue, all our patients fatigue does, it's important to rule out anemia, thyroid disorders, vitamin deficiency, sleep disorders, or a cancer as tenure-related. For study the dyspnea, it's important to rule out a pulmonary embolism, and if the patient explains tachycardia as well. It's important to ask for example, a spirometry to confirm if the patient has COPD or asthma, and think on echocardiogram if we thought that the origin of the dyspnea it has a cardiac origin. With the CUF, we have to think on the gastrointestinal reflux too. And you know that our patients have chest pain, tachycardia, and orthostatic intolerance. It's really important to rule out in patients that has anginal chest pain, a microvascular angina, and a coronary artery disease with cardiac stress evaluations or with coronary CT. And in our center, for example, if the patient explains very well these angina's pain, we rule out cardiac MRA with adenosine that finds in some patient an alteration in the endocardial perfusion, subendocardial perfusion. If we are thinking on inappropriate sinus tachycardia, we rule out anemia, pulmonary embolism, pheochromocytome with an urinary test, and we do a Holter 24 hours too. And finally, about the dysautonomic symptoms, we add in our evaluations an ASA test, and if it's possible, because in our center we don't have that, a tilt table test to confirm or not a POTS. If we are thinking in that our patients have maybe arthralgia or myalgia because a rheumatological disease, we add an autoinflammatory profile. And in relation to gastrointestinal disturbance, the most important thing is that to rule out, for example, a Helicobacter pylori in patients that has a lot of distension or epigastric pain, and think and open our mind in some onset of inflammatory bowel disease, food intolerance, and celiac disease too with colonoscopy, calprotectin, or stool culture. Finally, in relation of the neurological symptoms, the headache, it's really common in our patients, but we have to have in our mind the red flags and make a cranial CT if we need. And in relation to the neurocognitive dysfunction, we need to think, obviously, in sleep disorders too, medication, side effects, and do neurological test or brain MRI if it's necessary. This is a guide for primary care, and in red we have the red flags of these symptoms. And finally, the conclusions are that we need to do a full clinical history because we are internists, but it's really important, the paper of the primary care professionals. It's a complex and multi-system disease, and it's important to not attribute these persistent symptoms only to long COVID. It's important to investigate other causes, but it's really important to manage these patients by symptoms and emphasize on holistic support, avoiding over-investigation. Thank you very much.